Okay, so let us acknowledge the Lord. Let us press on to acknowledge him. As surely as the sun rises, he will appear. He will come to us like the winter rains, like the spring rains that water the earth. Hosea 6:3. Okay, let's start. Okay, ADHD. We left on ADHD. The goal is to reach 150, and we should do that. Let's see. So we currently are on 71. Okay, ADHD is when the child is hyperactive in two situations, two settings, and symptoms must present before age 12, and the treatment is stimulants, specifically give methylphenidate and amphetamines, okay? Alright, next. 72, PTSD, you give SSRI, which is the first line of treatment. Duration needs to be more than 1 month in length. So for a diagnosis of PTSD, the duration needs to be more than 1 month in length. Yeah, the duration needs to be more than 1 month in length, and you give SSRI, which is the first line of treatment. What are the SSRIs? It is a fluoxetine, it is a sertraline, it's citalopram. These are all SSRIs, okay? Now, 73. Schizophreniform disorder is between 1 and 6 months. The same symptoms as schizophrenia, and functional decline is not required. However, in schizophrenia, functional decline is required. Okay, so in schizophreniform disorder is between 1 and 6 months. So for these psych disorders, especially in schizophrenia, what you really have to know to differentiate is the timeline. So schizophrenia, you need a functional decline along with the 2 of the 5 symptoms, with one of them being hallucinations, delusions, and disorganized speech. Those symptoms need to be there for 6 months. Now, in schizophreniform, it is between 1 and 6 months. It is the same exact symptoms that's required for schizophrenia. It's the same symptoms for diagnosis, but functional decline is not required to have a schizophreniform diagnosis. Okay? 74. Suppression is a mature defense mechanism in which an individual intentionally puts aside unpleasant thoughts, feelings to cope with. They put aside unpleasant thoughts and feelings to cope with present reality. In contrast to repression, the individual is aware of the emotion but decides not to attend to it. For example, an adult who was molested as a child unconsciously hides unconsciously hides um, unconsciously buries feelings about the trauma. So suppression is a mature defense mechanism involving a conscious choice not to dwell on a particular thought or feeling. Okay, so suppression is a mature defense mechanism in which an individual intentionally puts aside unpleasant thoughts to cope with reality. In contrast to repression, the individual is aware of the emotion but decides not to attend to it. For an adult, like an adult who was molested as a child, unconsciously buries feelings about the trauma. Okay, so suppression is conscious, repression is unconscious. Okay. Alright, so suppression is a mature defense mechanism involving conscious choice not to dwell on the particular thought or feeling. Alright, 75. Bulimia nervosa. Fluoxetine is the drug of choice. Okay. Yeah, fluoxetine is the drug of choice. Bulimia nervosa, people see Russell's sign. Remember the bruised knuckles? That's a sign of bulimia nervosa. Okay. Yeah, fluoxetine is a drug of choice. 76. Olanzapine is an antipsychotic associated with weight gain. It has been used as an adjunctive treatment to psychotherapy for anorexia nervosa. Okay. Olanzapine is an antipsychotic associated with weight gain. It has been used as an adjunctive treatment to psychotherapy for anorexia nervosa, olanzapine has no role in treatment of bulimia nervosa. So olanzapine has been used for anorexia nervosa because one of the side effects of olanzapine is metabolic syndrome. So I mean, normally you don't want that, but anorexia nervosa is of course um, a specific eating disorder, right? So you can give olanzapine in as an adjunctive therapy to somebody that is anorexic, but never to somebody that is bulimic. Okay, 77. Acknowledging sexual abuse and gently asking if the patient wants to discuss the abuse further is the most appropriate response. Make sure the response involves support and empathy. So in regarding sexual abuse, gently asking if the patient wants to discuss the abuse further is the most appropriate response. Okay, all right. Cocaine withdrawal is marked by development of acute depression. Cocaine withdrawal is marked by the development of acute depression accompanied by fatigue, vivid dreams, and hypersomnia and hyperphagia. Okay, so somebody's withdrawing from cocaine. You have acute depression and fatigue, vivid dreams, hypersomnia, and hyperphagia. Okay, remember hyperphagia, okay? Okay, heroin withdrawal. You have vomiting, abdominal cramping, and muscle aches and nausea. And exam findings show dilated pupils, yawning, piloerection, lacrimation, and hyperactive bowel sounds. Okay, so heroin, which is an opioid, if you're withdrawing from an opioid, remember opioid intoxication, you see meiosis. So if you're withdrawing from opioid, you're going to see mydriasis, which is dilated pupils. Your pupils will be dilated, okay? So this is mydriasis. Let me show you. Okay, so this is mydriasis, okay? Meiosis, where's me? Okay, well, this is a good picture. So this is mydriasis, you see the pupil dilated. This is meiosis, you see the pupil very, very small. Okay, so this is a sympathetic reaction. This is the parasympathetic reaction. So think about it. If a lion is coming to attack you, you're gonna wanna have your eyes big to see the lion. That's why you want to see it from coming from 100 miles away, knowing that you're dead anyway. But so that's mydriasis. This is meiosis. So in mydriasis is what you see in opioid withdrawal. Okay, so let's see. Yawning, piloerection. What is piloerection? I believe that's a little hair standing up. Piloerection. Yeah, it's goosebumps. Yeah. So piloerection. See this? Look. See? So that's piloerection. So when you're scared, or you're undergoing heroin withdrawal, lacrimation. You are like your eyes runny, hyperactive bowel sounds. Yeah, because heroin intoxication or opioid intoxication causes a constipation. So when you're withdrawing from it, your stomach is going to be running. All right, benzodiazepine withdrawal. You have tremors, anxiety, perpetual disturbances, psychosis, insomnia. Okay, yeah, I mean that makes sense. Benzodiazepines will put you to sleep. If you take enough, they'll put you to sleep. So think about it. If you're withdrawing from it, it will cause you insomnia. Okay, exam findings shows seizures, tachycardia, palpitations. 84. No, 81. An instruction to leave the bedroom if you are not able to fall asleep. An instruction to leave the bedroom if you're not able to fall asleep is an example of stimulus control therapy. The goal of stimulus control therapy is to disassociate the bedroom for any stimulating activities that do not involve sleep, reading, TV, eating, and the fear of not sleeping. An instruction to leave the bedroom if you're not able to fall asleep is an example of stimulus control therapy. The goal of stimulus control therapy is to disassociate the bedroom from any stimulating activities that do not involve sleep. Okay, reading, TV, eating, and the fear of not sleeping. I think they're saying if you're trying to sleep, you can't sleep. Um, t- uh, um, okay, so basically, if you have to eat TV, all that, don't do it in the room. Use the room only for sleeping. This is an example of stimulus control therapy. 85. Schizoid personality disorder. These people are aloof and socially detached and not friendly or forthcoming, and don't but they don't have um, let's see, I don't have I'll look it up. That got wiped out. Let's look it up. Schizoid. Okay. Yeah, voluntary social withdrawal, limited emotional expression, content with social isolation versus avoidant. Okay. So, next, delusional disorder. What is delusional disorder? Oh, great. Yeah, so schizophrenic form disorder, see this? More than symptoms in 2 or more symptoms lasting 1 to 6 months. Schizophrenia is exactly what we said. 2 or more symptoms, um, with one being 1, 2, or 3 for 6 months. Delusion disorder, more than one delusion lasting 1 or more delusion lasting more than 1 month, but without a mood disorder. or other psychotic symptoms. Daily functioning, including socialization, may be impacted by the pathological fixed belief that is otherwise unaffected. Can be shared by individuals in close relationships. Okay, we do. So, delusional disorder is having um, more than one delusion, one or more delusions. More than one delusions lasting more than a month. More than a month. But without mood disorder or other psychotic symptoms. These people, they go to work just fine. Okay. Um, it doesn't impair their social functioning too much, like daily functioning. Yeah, I mean they're able to hold. It's not functional decline. They just believe the neighbors are like poisoning them or something. All right. Yeah, it's not functional decline typically. All right. We're gonna come back with conversion disorder, which is 87. Give me 5 minutes. Okay, so uh, we are on conversion disorder. It's a neurological symptom unexplained by any known neurological disease. They have acute onset, which is associated with mental stress. Most present as a neural problem. Yeah, conversion disorder is a neurological symptom unexplained by any known neurological disease. They have acute onset, which is associated with mental stress. Most present as a neural problem. Somatic symptom disorder. Somatic symptom disorder um, is marked by excessive and persistent health anxiety with multiple somatic symptoms. These patients do not have loss of function or neural, sensory, or motor. Somatic disorder patients complain of anxiety in one or more organ systems. Yeah, so somatic, they think they have so many issues. Like they think they have um, uh, lung cancer, stomach cancer, brain cancer. Okay, they always um, want so many checkups. Somatic symptom disorder. Yeah, that's the one where you schedule regular visits with the same provider, usually with the PCP, until um, until um, you establish a good relationship. Then only do you refer the patient to a psychiatrist. Okay, all right. Okay, so think of somatic symptoms. They think of so many symptoms. Think of something. I have this, I have that, I have that. So, and once you rule out that they don't have any diseases, then you keep referring them back um, to your office. Never refer away. Okay, because they truly they believe they have an illness. An illness. It's an unconscious um, thought. This is somatic symptom disorder. 89. All patients who present to the ED must receive an appropriate screening, medical exam, and stabilization of their condition regardless of ability to pay. Okay, so anyone who comes to ED must receive an appropriate screening, medical exam, and stabilization of their condition regardless of ability to pay. Okay. Rett syndrome. Loss of speech and motor skills, decreasing head growth, and stereotypic hand movements after a period of normal development. It affects mainly girls and is associated with mutations in MECP2 gene. Child will develop normally until age 5 to 18 months. Then there's a loss of motor and language skills and development of stereotypic hand movements. Okay, that is Rett syndrome. Yeah, so loss of speech, motor skills, and the head shrinks. Um, let's see if we can find a picture. And they grow normal. That's the thing. They grow normally until age 5 to 18 months. Let's see. Yeah. See how the head stops growing? It stops growing for their age. Yeah. Okay. And they have wringing of the hands, okay? They, let's see, wringing of the hands, repetitive hand movements, flapping, clasping hands. Oh, okay, so they can't walk, eat, or breathe. This is so sad. That is such a sad disease. Imagine a child being completely healthy up until they're like a year, and then suddenly they get. Oh, that's heartbreaking. Mhm. Yeah, I think that would be the biggest shock to me too. Like, it's one thing if a child is born with complications. It's another if they're born absolutely healthy, they understand everything, they're reaching all their milestones, and then one day you find a kid is going to die because they stop like physically, mentally stop growing, and yeah, they're yep. Yeah, loss of motor, language skills, development of stereotypic hand movements. Yep. Okay. Number 99. Majority of completed suicides occur uh, with use of a firearm. Be sure to ask in history if they have access to firearm. Yeah, majority of completed suicides occur with the use of firearm. 82. Diphenhydramine is highly anticholinogenic, so it can cause urinary retention and constipation, especially in the elderly. So diphenhydramine is highly anticholinogenic, so it can cause urinary retention and constipation, especially in the elderly. Other anticholinergic side effects include impaired memory, confusion, hallucinations, dry mouth, blurry vision, impaired sweating, tachycardia, and increased fall risk. Okay, so diphenhydramine is highly anticholinergic. It can cause urinary retention and constipation, especially in the elderly. Okay. Can cause urinary retention and constipation, especially in the elderly. Other anticholinergic side effects include impaired memory, confusion, hallucination, dry mouth, blurry vision, impaired sweating, tachycardia, increased fall risk. So use anticholinergic carefully, like this diphenhydramine. You use it sparingly in older people because you don't want to give them urinary retention and constipation. You don't want to make it worse. And also, um, yeah, it's a company with increased fall risk, so don't give. If you can avoid it, avoid it. Okay. 93. Major depressive disorder. Patient develops psychotic symptoms during the depressive episode. Delusions and hallucinations are commonly mood congruent and have depressive themes. De- um, Deserved punishment, worthlessness, nihilism. Although mood incongruent psychotic symptoms can also occur, the diagnosis is made only if psychotic symptoms are present during the episode of major depression. Treat with antidepressant and antipsychotic. So, major depressive disorder. Patient develops psychotic symptoms during the depressive episode. Um, Remember, if a patient develops psychotic symptoms during the depressive episode, it will be major depression with major depressive disorder with psychotic symptoms. Usually, the delusions and hallucinations are mood congruent, which means that if somebody with a major depression, they have a depressive themes like they deserve the punishment, the world is coming to an end, they feel guilty, they have suicidal thoughts. That is the kind of um, um, thoughts and delusions and hallucinations they will have, although mood incongruent psychotic symptoms can also occur. Mm, the diagnosis is only made if psychotic symptoms are present only during the episode of major depression. Treat major depressive disorder with antidepressant and antipsychotic. 94. Doctors are justified in obtaining a court junction to proceed with life-saving medical treatment of the child. Okay. Doctors are justified in obtaining a court junction to proceed with life-saving medical treatment of the child. So if a parent is receiving life-saving treatment to a child, doctors are 100% justified in getting a court junction to proceed with the treatment of the kid. Okay? And that has to be life-saving medical treatment. 95. The only serotonin releasing neurons in the CNS are found in the Ralphie nuclei. Okay, the Ralphie nuclei. Let's look this up. So this is the Ralphie nuclei, right? Ralphie nuclei, right here. That's Ralphie nuclei. Yeah, that's the Ralphie nuclei, and that is that's the only serotonin releasing neurons in the CNS that are found in the Ralphie nuclei. So that's where serotonin is released from. Okay, in the CNS, the Ralphie nuclei. 96. Nucleus basalis of Maynard has cholinergic. Okay, nucleus basalis of Maynard has cholinergic neurons. In Alzheimer's disease, these cholinergic neurons secrete decreased acetylcholine. Okay, nucleus basalis of Maynard has cholinergic neurons, which are parasympathetic neurons. In Alzheimer's disease, you have decreased acetylcholine. Nucleus basalis. Frontal cortex. Okay, so this is the nucleus basalis of Maynard right here. Okay. It has cholinergic neurons. In Alzheimer's disease, these cholinergic neurons secrete decreased acetylcholine. So you have to know that in Alzheimer's disease there is increased acetylcholine, okay? Alright. And acetylcholine is secreted from the nucleus basalis of Maynard. See this? It's been well established that neuronal loss within the cholinergic nucleus basalis of Maynard correlates with cognitive decline in dementing disorders such as Alzheimer's. Yeah, so in Alzheimer's you have neuron loss in the nucleus basalis of Maynard. 97. Huntington's disease. There's a loss of cholinergic and GABA releasing neurons in the striatum. Okay. Okay. Huntington's disease, loss of cholinergic and GABA releasing neurons in the striatum. Okay, striatum is. Striatum is here. Okay. Substantia nigra has dopaminergic neurons. Yes, substantia nigra has dopaminergic neurons. Substantia nigra has dopaminergic neurons. In Parkinson's disease, these neurons are depleted. Substantia nigra. Okay, so in the striatum, that is where that's what is affected in Huntington's disease. Nosocolinergic and GABA releasing neuron. Okay. Substantia nigra. Substantia nigra. Okay, so this is the substantia nigra. That's where the dopaminergic neurons are. In Parkinson's disease, these neurons are depleted. In Parkinson's disease, the dopamine neurons are depleted in the substantia nigra. Okay. Okay, 99. Olanzapine, metabolic adverse effects like weight gain, dyslipidemia, hyperglycemia, and increased risk of diabetes. Olanzapine and clozapine carry the highest risk. Like for metabolic adverse effect. That's why we said in anorexia nervosa we can give olanzapine as a adjunctive therapy. Okay, under risperidone, there's increased prolactin levels in the blood. Yeah, there's increased prolactin levels in the blood. Risperidone, increased prolactin levels in the blood. Yeah, so risperidone causes hyperprolactinemia, okay? Risperidone is it's an antipsychotic. Let's say risperidone. Yeah, risperidone, antipsychotic. It causes hyperprolactinemia. Okay. 101. Treating friends and family is only ethically justifiable in the case of an emergency. So, yeah, in the medical field, you do not treat your friends or you do not treat your family because you're gonna have clouded judgment, and that's problematic to the patient and you too. 101, 102. Diagnosed to have schizoaffective disorder. This causes psychosis. Um, yeah, diagnosis of schizoaffective disorder. Diagnosis of schizoaffective disorder. Psychosis. There's voices and bizarre delusions, and must have okay, diagnosis of schizoaffective disorder. Um, diagnosis of schizoaffective disorder. The psychosis, which is voices and bizarre delusions, must happen in the absence of major mood episodes. I mean, yeah, if somebody has schizoaffective disease, um, the delusions must happen when they don't have mood episodes. So they have to be psychotic most of the time without mood episode. You must have at least 2 weeks of psychotic symptoms without any mood symptoms, but psychotic symptoms do need to present majority of illness, whether that be 1 year or 6 months. Yeah, um, you need to have psychotic symptoms most of the year. Okay, let me just write that down. Psychotic, but psychotic. Okay, so that's schizoaffective disorder where the psychotic symptoms do need to be present for most of the year. Okay. 103. Uh, psych- Psychotropic drugs like antipsychotics, antidepressants, and benzodiazepines have increased fall risk. Side note: amlodipine, and ibuprofen are both associated with increased fall risk. Amlodipine. What is amlodipine? Amlodipine. Calcium channel blocker. Okay, this is an antihypertensive drug. Mm, and okay, so amlodipine, and ibuprofen are both associated with increased fall risk. Look at medication review in elderly people that come from nursing homes for increased fall risk. So, if elderly people are on amlodipine, ibuprofen, or antipsychotics, or antidepressants, or benzodiazepines, um, take them off of it if they're continuously falling, or if they have risk of falling, take them off. Okay, 104, bupropion. It's an atypical antidepressant that increases norepinephrine and dopamine levels, but bupropion also lowers the seizure threshold. So bupropion is contraindicated in bulimics and anorexics because bupropion lowers the seizure threshold. Because excessive vomiting will result in hypokalemia, and elevate seizure risk, bupropion cannot be given in anorexics or bulimics. Okay, so bupropion is an atypical antidepressant. It increases norepinephrine and dopamine levels, but you cannot give it to anyone that are at high risk for having a seizure, like anorexia patients and bulimia patients. So bupropion is contraindicated in bulimics. So what do you give bupropion for? Okay, you can get for MDD. Bulimia nervosa, bupropion is contraindicated. Nicotine. Oh, for nicotine, yeah. That's right. For smokers, you give nicotine patch, gum, lozenges, or bupropion, or varenicline. Alright, so bupropion is given for smoking cessation. I'm making note of that. Bupropion is given for smoking cessation. Okay, so how do you remember that? Because people get mixed up between bisphoron and bupropion. Bupropion, think of it as positive. There's two P's in there, positive. So it's something positive you give for smokers, right? So quitting smoking is a very positive thing. It's one of the life's greatest achievements. So think of it that way. Bupropion is given for stopping smoking. Okay. Bisphoron is given for GAD, generalized anxiety disorder, like second line therapy. Okay? Alright. Antidepressant monotherapy should be avoided in patients with bipolar disorder due to risk of causing mania. So yeah, giving antidepressants should be avoided in patients with bipolar due to risk of causing mania. 106, transference. Transference is when you unconsciously shift emotions, desires associated with a person from the past to another person in the present. Transference can be negative or positive. So, like doctor-patient relationship, um, the patient transfers his feelings of, let's say the kid had like trauma from being neglected as a kid, um, and then the doctor's hearing all this, and then that patient now sees the doctor as like the person from the past. I think transference. Yeah. So somebody like a doctor-patient relationship, the patient had like past trauma as a kid. Maybe he was neglected, and then the doctor says like he couldn't make one appointment, and the doctor said and he had to cancel due to an emergency that came up, and then and the patient says, "Oh, you're just like my dad. You don't care about me." That's like that's transference. So yeah, and when the doctor shifts their feelings and emotions onto the patient, that's countertransference. Okay. 107, methadone is prescribed for maintenance of opioid abuse. It's a potent, long-lasting, it's a potent, long-acting, long half-life drug, which means you don't get acute withdrawal or craving, so patients can function more productively on a daily basis. Methadone is a full mu opioid receptor agonist used for chronic pain, opioid withdrawal, and for maintenance treatment of addiction. Okay, so okay, so unconscious shifting. Okay, that's transference. Methadone is prescribed for maintenance of opioid abuse. It's a potent, long-acting, long half-life drug, which means you won't get acute withdrawal or craving, so patients can function more productively on a daily basis. So it stays in your body for a long time. Is what it's saying. So the patients won't get the craving. The patients can function like normal until they get off of their addiction, until they're weaned off their addiction. Methadone is a full mu opioid receptor agonist used for chronic pain. Used for chronic pain, opioid withdrawal, and for maintenance treatment of addiction. Chronic pain, opioid withdrawal, and for maintenance treatment of addiction. Okay, 107. Somatic disorder, anxiety, fatigue, headaches, generalized abdominal pain, normal PE exam, and imaging test. The treatment is to have regular outpatient visits with the same provider. Don't forget, same provider. Okay. 108. Alcohol potentiates gamma aminobutyric acid, A, which is GABA receptors, and inhibits excitatory NMDA receptors. We talked about this. Chronic use leads to downregulation of GABA and upregulation of NMDA receptors. What does it do? Alcohol potentiates gamma aminobutyric acid, which is GABA A receptors. It, when you drink, it increases the GABA receptors in your body, which is why you get slow and sleepy. Okay, and then it inhibits the excitatory NMDA receptor. So if you increase an inhibitory action, you're gonna get slower, and if you inhibit the excitatory receptor, you're gonna get slower. That's why people who drink are, they sleep. Eventually, they fall asleep. But chronic use leads to down-regulation of GABA and up-regulation of NMDA receptors. Okay, remember that. Chronic alcohol use leads to down-regulation of GABA receptors, GABA A receptors, and up-regulation of NMDA receptors. 109. Second-generation antipsychotics like quetiapine cause a prolonged QT interval, hyperlipidemia, hyperglycemia, and also EPS, which is extrapyramidal symptoms. In extrapyramidal symptoms, you see rigidity, akathisia, dystonia. Okay, second generation antipsychotics like quetiapine cause a prolonged QT interval. Okay, prolonged QT interval. Okay, prolonged QT interval. Okay, remember this. Prolonged. This is normal QT right here, QT. But then quetiapine causes this. Okay, it stretches out the QT interval. Okay. Yeah, second generation antipsychotics like quetiapine cause a prolonged QT interval, hyperlipidemia, hyperglycemia, and also EPS, which is rigidity, akathisia, dystonia. 110. Panic disorder, you give paroxetine, first line. Okay. Panic disorder. I know it's SSRI. Well, I guess this question asked about paroxetine. Well, it's for paroxetine first line. So, paroxetine. 111. TCAs cause orthostatic hypotension. TCAs function by blockage of norepinephrine and serotonin reuptake, and they interact with other receptors, causing blockade of alpha receptors. This leads to orthostatic hypotension. Activation of alpha-1 receptors in the vascular smooth muscle causes vasoconstriction. So blockade of alpha-1 receptors can lead to decreased arteriolar resistance and post-urol hypotension. Blockade of alpha-1 receptors lead to decrease in phospholipase C and decreased calcium release. Okay, so TCAs cause orthostatic hypotension. TCAs function by blocking norepinephrine and serotonin reuptake, and they interact with other receptors, causing blockade of alpha receptor. This leads to orthostatic hypotension. Orthostatic hypotension. Yeah, so because you're blocking alpha receptors. Alpha receptor does what? It vasoconstricts. So if you block the alpha receptor, you're going to have vasodilation. So that's why it causes the hypotension. So activation of alpha-1 receptors in your vascular smooth muscle causes vasoconstriction. So blockade of alpha-1 receptors can lead to decreased arteriolar resistance and okay, so blockade of alpha-1 receptors can lead to decreased arteriolar resistance and post-urol hypotension. Blockade of alpha-1 receptors will lead to decrease in phospholipase C and decreased calcium release. Lead to decrease arteriolar resistance and post-urol hypotension. Okay, post-urol hypotension is just orthostatic hypotension. Okay, so TCAs cause hypotension. Okay, that's how they do it because they block alpha receptor, and that causes hypotension. And blockade of alpha 1 receptors lead to decrease in phospholipase C and decreased calcium release. Remember that. Blockade of alpha receptors leads to decrease of phospholipase C and a decreased calcium release. LSD abuse that causes hallucinations, delusions, dilated pupils, stable vital signs. Okay, so LSD abuse causes hallucinations, delusions, dilated pupils, stable vital signs. LSD can cause anxiety, depression, nausea, weakness, paresthesias. No antidote is available for LSD toxicity. Don't do drugs. Regardless of the situation, don't do drugs. LSD toxicity. Yeah, pupils is a dilation, profuse sweating, increased heart rate, nausea, high BP, muscles numbness, weakness, tremors. Okay. Alright, so that's that. So remember hallucinations, delusions, dilated pupils, stable vital signs, okay? LSD, think like you're worried the cops are gonna come get you, so your eyes are gonna be dilated. Okay? And remember hallucinations and delusions. I just remember like those TV shows that literally this is what we see. They're hallucinating. They think they're in a club. They think somebody's hitting on them. They imagine like dead people. Remember those little shows that we had? They tell you don't do drugs. It's just like in our school they had a whole campaign and they showed us so many things where they said this is what happened to you if you do drugs. Oh my gosh, that was the most traumatic video I've ever seen, and I was just like, That being said, crap happens, and people fall into all kinds of things, and it's very unfortunate. But that's why we're here. We're doctors. We got to treat everyone for everything. Addiction is a disease. Okay? Alright. Now, let's see. 113. Lithium impairs the ability to concentrate urine in a dose-dependent manner. This causes a disorder called nephrogenic diabetes insipidus, in which the patient excretes large quantities of dilute urine. Okay. Lithium also causes hypothyroidism and Epstein's anomaly in a fetus if it is given during pregnancy. Okay, lithium impairs ability to concentrate urine in a dose-dependent manner. This causes a disorder called nephrogenic diabetes insipidus, in which a patient excretes large quantities of dilute urine. Okay, look at this. Nephrogenic diabetes insipidus. Okay, nephrogenic diabetes insipidus. this is what I was looking for. Nephrogenic diabetes insipidus. Okay, so here, nephrogenic diabetes insipidus is the one you get from lithium. So, but people in bipolar patients get this. So hereditary. It's hereditary because of ADH receptor mutation, secondary to hypercalcemia and hypokalemia. Lithium demiocycline, ADH antagonist. Okay, so this is the one. This is the one where you can't concentrate urine, so there won't be much change in osmolarity, which is the number of solutes in the urine. So let's get to this. 388. Okay, so nephrogenic diabetes insipidus is hereditary. It's due to ADH receptor mutation. Demiocycline is given for SIADH. Hypokalemia. Without potassium, V2 receptors won't work. Okay, without potassium, V2 receptors won't work. Okay. So normal, increase ADH. So the normal job of ADH is to hold back free water and dilute blood, so level of sodium cannot increase too much, and we get it back to normal. Diabetes insipidus means there's no ADH, which means no holding back free water, and there is no dilution of blood, because of which level of sodium will increase hypernatremia and give you hyperosmolarity. If you don't hold back the water, you will lose water, and blood and volume will decrease, which gives you volume contraction. Contraction means shrinkage. Okay. Because V2 receptor defective, so desmoproline cannot work on V2 receptor. So the urine osmolarity, if it's less than 300, the urine is dilute. Okay. Serum osmolarity, if it's greater than 290, the blood is concentrated. So ADH, what is ADH? ADH is because V2 receptor defective, so desmopressin won't work on the V2 receptor. Okay. So basically nephrogenic diabetes is you pee out all your water due to no ADH, but solutes are retained. So the entire job of ADH is to hold back water and dilute the blood. Here, there is no ADH in nephrogenic diabetes, so there's no ADH, there's nothing to hold back water, so you pee out all your water. Okay. So the level of sodium cannot increase too much. Okay. normally the job of ADH is to hold back free water and dilute the blood. So level of sodium cannot increase too much, and we can get it back to normal. Diabetes insipidus means no ADH, which means no holding back free water and no dilution of blood, because of which level of sodium will increase and hypernatremia will give you hyperosmolarity. If you don't hold back water, you lose water, and blood volume will decrease, which makes you volume contraction, shrinkage. Yeah, so basically you pee out your water, and then your blood will be concentrated because you peed all your water out. Alright, so the treatment for nephrogenic diabetes is this is what we're talking about, nephrogenic diabetes. The treatment is hydrochlorothiazide, indomethacin, amiloride, hydration, dietary salt restriction because you already have too much salt in your body, avoidance of offending agent. So you pee out all your water due to no ADH, but solutes are retained. Okay. So lithium impairs ability to concentrate urine in a dose-dependent manner. This causes a disorder called nephrogenic diabetes insipidus, in which the patient excretes large quantities of dilute urine. Lithium also causes hypothyroidism and Epstein anomaly in a fetus if it is given during pregnancy. Okay, so yeah, you pee out all your water due to no ADH, but solutes are retained. Because V2 receptors defective, so desmopressin cannot work on V2 receptor. So in nephrogenic diabetes, the V2 receptors are defective, so desmopressin cannot work on V2 receptor. So you'll have dilute urine even after giving ADH analog. Okay, so how do you differentiate between central diabetes insipidus and nephrogenic diabetes insipidus? In central diabetes insipidus, the desmopressin will work on it and will increase the urine osmolarity like in normal people, but in nephrogenic diabetes, it will not work, the desmopressin. And won't be able to increase urine osmolarity because desmopressin works on V2 receptors in the kidney, and V2 receptors are defective in nephrogenic diabetes insipidus. So that's how you differentiate. Even if you give desmopressin, which is ADH, right? Desmopressin. Yeah, desmopressin is ADH. So in diabetes, nephrogenic diabetes insipidus, the V2 receptors, which is what desmopressin works on, is defective. So this drug cannot work on nephrogenic diabetes insipidus to hold back the water. That's why you have dilute water. But in central diabetes insipidus, there is nothing wrong with the V2 receptor, so ADH will work. That's why the urine will be concentrated in central diabetes insipidus. Okay. So in diabetes, central diabetes insipidus, you have decreased ADH. See this? You have decreased ADH. Diabetes in nephrogenic diabetes insipidus, you have normal or increased ADH levels, because that's not the problem. It's the V2. It's a receptor issue. It's a V2 receptor issue. ADH receptor issue. See? That's why even though you have plenty of ADH in the body, it doesn't matter because it cannot work on the V2. And here, central diabetes insipidus, you just have decreased ADH. The problem is decreased ADH. You give ADH and then it will. There will be more than 50% increase in urine osmolarity only after administration of ADH analog. Remember that. And so the treatment is desmopressin, okay? And then hydration. Here, hydrochlorothiazide, indomethacin, amiloride, hydration, dietary salt restriction, avoidance of offending agent. Okay, all right. Okay. So no water intake for 2 to 3 hours, followed by hourly measurements of urine volume, as well as plasma concentration and osmolarity. No water intake for 2 to 3 hours, followed by hourly measurement of urine volume and osmolarity, as well as plasma, sodium concentration, osmolarity. No water intake for 2 to 3 hours. No water intake for 2 to 3 hours, followed by hourly measurements of urine volume. No water intake. No water intake for 2 to 3 hours, followed by hourly measurements. No water intake for 2 to 3 hours, followed by hourly measurements of urine volume and osmolarity, as well as plasma, sodium concentration, and osmolarity. ADH analog, which is desmopressin, is administered if serum osmolarity is greater than 295 to 300. Plasma sodium over 145, or urine osmolarity does not rise despite a rising plasma osmolarity. So basically, there's no water intake for 2 to 3 hours, followed by hourly measurements of urine volume and osmolarity, as well as plasma, sodium concentration, osmolarity. ADH analog, which is desmopressin, is administered if serum osmolarity is more than 295 to 300. Oh, to pee the solids out. Okay. And then plasma, and then if plasma sodium is greater than 145, yeah, to pee the plasma, to pee the sodium out, or urine osmolarity does not rise despite plasma osmolarity. That means there's, yeah. So basically, the urine solutes doesn't go up as blood osmolarity is going up. You give desmopressin. Okay. So in both of these, it's intense thirst and polyuria with an inability to concentrate urine due to lack of ADH central or failure response to circulating ADH nephrogenic. Yeah, so in diabetes insipidus you have increased blood osmolarity. You have increased blood osmolarity. And urine is dilute. Yeah, urine is dilute if it's under 300. If blood is over 290, is concentrated. So that is what is seen in both diabetes insipidus and nephrogenic insipidus, okay? Don't forget that. And the goal is to make the urine more concentrated. And the blood less concentrated under under 300, and to make the sodium under 145, and urine osmolarity, it needs to be higher. Yeah. Okay. Okay, next. Flufentanil is given in benzodiazepine overdose. Work by displacing a drug from its binding site. Organophosphate poisoning, you give pralidoxine. Okay, organophosphate poisoning, you give pralidoxine. Okay, so panic disorder, recurrent, unexpected panic attacks. People worry when the panic attack will happen. Next, they limit their activities of going places as a result. Okay, 118. In U.S., majority of overdose deaths are caused by prescription drugs, particularly prescription drugs like opioids. There is more deaths than heroin. There is more deaths than heroin and cocaine combined. Okay. So that's why doctors in general, they don't like to prescribe opioids. 119. Weed contains tetrahydrocannabinol, which stimulates cannabinoid receptors to produce a mild euphoria and inappropriate laughter. Two-minute break. Okay. So, weed contains tetrahydrocannabinol, which stimulates cannabinoid receptors to produce a mild euphoria and inappropriate laughter. Increased appetite, slow reaction to time, motor, speed, and cognitive impairment. Tachycardia and conjunctival injection, the two most immediate physical symptoms of marijuana use. Once inhaled, effects last 1 to 4 hours. Cognitive impairment includes a decreased attention, decreased concentration, decreased short-term memory, and judgment. It's metabolized in the liver and can be detected in urine up to 30 days after daily use has stopped. Okay, so weed contains tetrahydrocannabinol, which stimulates cannabinoid receptors to produce a mild euphoria and inappropriate laughter, increased appetite, slowed reaction time, slowed reaction time and motor speed, and cognitive impairment. Tachycardia and conjunctival injection are the most immediate physical symptoms of marijuana use. So conjunctival injection is this. Conjunctival injection. Okay, that's what this is. Inflamed eyes. So inflamed conjunctiva. Oh my goodness. Munchies, marijuana. Munchies, marijuana. The term munchies indicates enhanced appetite for food or food cravings that people may experience after using cannabis. Yeah, this is why you get this is why you have increased appetite after you have marijuana. It's called the munchies. Okay. Once inhaled, once inhaled effects last 1 to 4 hours. Cognitive impairment includes decreased attention, decreased concentration, decreased short-term memory and judgment. Its metabolism in the liver can be detected in the urine up to 30 days after daily use has stopped. Okay, so weed can be detected in the urine after 30 days, for up to 30 days. Okay, guys. All right. Okay. Let's see. 120. Mydriasis is seen in cocaine intoxication and opiate withdrawal. Remember that mydriasis is seen in cocaine intoxication, cocaine intoxication, cocaine intoxication, cocaine addiction, cocaine intoxication. Yeah, see this? Dilated pupils. Think like, remember we said LSD also causes dilated pupils, cocaine also causes dilated pupils. Just think the cops are coming for you, so you're gonna be like this. That's exactly your reaction when you do cocaine. Oh my gosh, the feds are coming for me. Okay, alright. Mydriasis is seen in cocaine intoxication. Opioid withdrawal, that is the only one that is that's the only, that's different. So you just have to remember that. I just remember that because I had this terrible picture of this guy. Like as soon as he takes opioid, um, his pupil like shrinks. Like it's literally a pinprick. And that's the image I have in my head for opioids. Um, so mydriasis is seen in cocaine intoxication and opiate withdrawal. Okay, mydriasis is seen in cocaine intoxication and opiate withdrawal. Okay. 121. At age 2, children should have a vocabulary of 200 to 300 words and be using two-word phrases. Okay? At age 2, children should have a vocabulary of 200 to 300 words and should be using two-word phrases. Language is the most commonly delayed milestone. Many children will catch up in preschool. Okay, at age 2, kids should be saying 200 to 300 words and be using two-word phrases. Like, give me. Okay. 122. Patient presents with drug-seeking behavior. The best initial approach is to clarify the patient's medication history, determine which drugs have been prescribed and by whom, and at what frequency. This is particularly talking about opioid-seeking behavior. Yeah, the best approach is to clarify the patient's medication history to determine which drugs have been prescribed by whom and to what frequency. All right. Don't accuse the patient. Okay. 123. Specific phobia. It's anxiety about specific object or situation for more than 6 months. Behavioral therapy, like exposure, systemic desensitization is the treatment of choice. SSRIs, not first line. Benzodiazepine can be used if no therapist is available. Yeah, because SSRIs take like 6 weeks to work. So benzodiazepine benzodiazepine can be used if there is no therapist available because it's fast acting. This is when somebody has a specific phobia. Okay. Yeah, there are anxiety about a specific object or situation for more than 6 months. For more than 6 months. For more than 6 months. Behavioral therapy, exposure, systemic desensitization, is the treatment of choice. Exercise, not first line. Okay. Benzodiazepine, if no therapist is available. 124, social anxiety disorder. This is excessive periods of scrutiny or embarrassment in social or performance situations, resulting in distress and functional impairment. So social anxiety disorder. Yeah, social anxiety disorder. Excessive fears of scrutiny or embarrassment in social or performance situations, resulting in distress and functional impairment. You see increased anxiety about more than or just one social situation for more than or equal to 6 months. You have increased anxiety about more than or just one social situation for more than or equal. Oh my goodness. You have increased anxiety about more than or just one social situation for more than or equal to 6 months. SSRI can be given. You can give beta blocker or benzodiazepine for those who only have performance only subtype, like speaking or performing in public. So if somebody is scared of dancing on stage, you can give benzodiazepine or beta blocker. If it's social anxiety disorder, like excessive fears of scrutiny or embarrassment in social or performance situations, resulting in functional decline, functional impairment, you can you have anxiety of more than or just one social situation for more than or equal to 6 months, you can give SSRI. Okay, let's look that up. That was a little confusing. Social anxiety. Social anxiety. So phobia, severe, persistent, more than 6 months. Fear or anxiety due to presence or anticipation of a specific object or situation. Person often recognizes fear as excessive. Treatment is CBT with exposure therapy. Social anxiety disorder, exaggerated fear of embarrassment in social situations like public speaking, using public bathrooms. Treatment is CBT, SSRI, venlafaxine for performance type anxiety like public speaking. Like you're only scared of public speaking, you can use beta blockers, benzodiazepines. Okay, so that's social anxiety disorder, public bathrooms, public speaking. More than one, but more than one, or just one social situation for more than or equal to 6 months, SSRI can be given. Okay, social anxiety disorder. Public bathrooms, public bathrooms, public bathrooms, public speaking, public speaking. public speaking, public bathrooms. You give SSRI, you give CBT, and flaxseed if they're just scared of speaking on stage or dancing on stage. Then you give beta blockers or benzodiazepine. Okay. Beta or beta blockers are BZDs. Okay. Next. Okay. 127. Factitious disorder, conscious and deceptive, feigning or self-induced physical symptoms to get attention and medical care from healthcare personnel. They want to assume the sick role to get sympathy. There is no financial gain in factitious disorder, but they do it for psychological gain, mainly seen in women and healthcare workers. Yep, okay. This is a factitious disorder. It's conscious and it's deceptive. They know they're doing it. It's self-induced trauma to get attention and sympathy. And medical care. They want to assume the sick role to get sympathy. There's zero financial gain, only psychological gain. 128. DNR includes three elements. The DNR includes three elements. There is no intubation or mechanical ventilation. DNR includes three elements. There is no intubation or mechanical ventilation. Number two, no defibrillation or IV drugs to acutely treat a rhythm. Number three, there is no chest compressions. DNR includes three elements. There is no intubation or mechanical ventilation. Number two, there is no defibrillation or IV drugs to acutely treat a rhythm. And number three is no chest compressions. No chest compressions. If someone is DNR, never do 1, 2, or 3, and the family should be allowed to be with the patient during his or her final moments. Number 129, in binge eating disorder, patients engage in recurrent episodes of binge eating, but do not use inappropriate compensatory behavior like in bulimia. So remember that in binge eating disorder, patients engage in recurrent episodes of binge eating, but they don't throw up. They don't stick their hand down their throat and throw up. Like in bulimia, that's the difference between bulimia and binge eating. Bulimia binges and it has inappropriate compensatory mechanisms, and it must occur at least once a week for 3 months. That's bulimia, okay? 130. Lithium causes weight gain, dry skin, hair loss, and constipation, bradycardia. These are the symptoms of hypothyroidism. Lithium causes hypothyroidism by decreasing thyroid hormone synthesis and release. Lithium also causes nephrogenic diabetes insipidus, like we just said. Lithium causes nephrogenic diabetes insipidus and hypothyroidism, okay? Don't forget. Let's see. Can we do it? Can we get up to, I don't think so, up to 150? I mean, I have no problem, but the problem is my recording stops at 2 hours. I'm afraid it might not make it. Should we just stop at 1:30? Okay, fine, we'll stop at 1:30, and then we'll continue from 1:30 tomorrow.